Welcome to the CMEssentials audiocast, covering current topics in clinical medicine. The show helps clinicians stay up to date on the current standards of care and catch up with the latest clinical developments and trends. Each episode features a lively discussion between the physician host and a noted clinical expert. They dig into the issues practitioners face every day and provide insight on improving patient care.
Hello, and welcome to another installment of Oakstone's CMEessentials in Family Medicine. I'm your host, Dr. Doug Paauw. I am a professor of medicine at the University of Washington School of Medicine, and I am very pleased to be with you today to cover the management of Clostridium difficile infection. Managing patients with C. diff used to seem so simple. Just stop the offending antibiotic and treat with metronidazole. But it is becoming increasingly more complex for reasons we will get into. I am joined today by my colleague, Dr. Paauw Pottinger, professor of medicine in the Division of Allergy and Infectious Disease here at the University of Washington. Thanks so much for being here, Paauw.
Well, Doug, it's my total pleasure. Any opportunity I get to hang out with you, I love it. Any topic. And why not diarrhea? Let's do it.
Great. Well, our discussion is going to be presented in two parts. In part one, we will start with a general overview, then talk about risk factors and patient workup, and finish with the discussion on treatment options. In part two, we will dive into the very challenging aspect of treating recurrent C. diff infections. We will be incorporating a case study into our talk to showcase how to implement best practices. We'll end each part reviewing key take-home points. Let's go ahead and get started. I want to start by laying the groundwork for why the topic is so important for primary care clinicians. C. diff is the most commonly reported nosocomial pathogen in the U.S. and the main cause of antibiotic-associated diarrhea and pseudomembranous colitis. If not caught early, severe cases can lead to toxic megacolon, colonic ileus, sepsis, and death. As primary care clinicians, our role is to identify C. diff early, manage them effectively, and keep patients out of the hospital. Dr. Pottinger, is there anything you wish to add to this general introduction?
Yeah, well, just that I hate C. diff so much. I hate everything about it. Every last feature of this stupid germ drives me crazy. Even the name. They've recently renamed it. You've seen this, Doug? They rebranded it. It used to be called Clostridium difficile. It's now called Clostridioides difficile. No one calls it that. I just call it C. diff. I call it by other names that I won't share on this very nice production. I hate this germ because it's such a huge, huge problem. It's a big bowl of bad. According to Centers for Disease Control in Atlanta, yeah, C. diff causes almost 500,000 infections in the U.S. every single year. And it's a curse that can come back. About 1 out of every 6 patients with C. diff infection will have another C. diff infection within the coming 2 to 8 weeks. Which is horrible. And that's the good news, right, Doug? Because actually the bad news, 1 out of every 11 people who's over the age of 65, diagnosed with healthcare-associated C. diff infection, will die within the coming month, either directly because of C. diff or with C. diff. So this is a problem, and all doctors are familiar with it. Now, when I was in training back in the day, we considered C. diff infection to be a hospital problem. Patients catch it in the hospital, our dirty environment, we give them IV antibiotics. Now, that's true. That is a real thing. But unfortunately, that's no longer the whole story. Now we understand that C. diff happens in our outpatients as well, to a surprisingly common amount of the time. Maybe 1 out of 4 cases, about 25% of cases diagnosed in primary care or urgent care out of our national numbers. That's a really big proportion to me. So C. diff, not just a hospital issue anymore.
Those are sobering statistics, Paauw. Of course, we frontline clinicians see many patients who come in with diarrhea. We get a lot of phone calls about diarrhea. What should we do about it? The key is to spot those who are at risk quickly. Paauw, will you walk us through the risk factors we should think about when we suspect or want to rule out C. diff?
Yeah, sure. My pleasure. So it's really funny. When patients seek care for their diarrhea, we call that medically attended diarrhea. MAD, M-A-D, MAD diarrhea. I love that because I get mad every time I have to see this in my practice. I love that term. But you'll see MAD diarrhea in the literature. Now, not all medically attended or MAD diarrhea is C. diff, of course. And to make it even more challenging for frontline clinicians, there's lots of healthy people Maybe I'm one of them. Maybe you are, Doug. A lot of us walk around colonized with toxigenic C. diff bacteria, harmlessly colonized, meaning the bacteria are present in our GI system, but their numbers are under control because they have a lot of competition with the healthy microbes of the gut. And so the little bit of toxigenic C. diff we have, it's not making toxin. That's good. The bad news, stool tests cannot tell the difference. A stool test of a colonized person versus an infected person, they can both be positive if we send them to the lab. So the challenge for the astute primary care clinician is to figure out whom to test in the first place. We don't want to miss C. diff infection. We also don't want to overdiagnose it. So we should only test when appropriate. Now, you asked about risk factors for catching C. diff infection. I'll sometimes call that CDI, C. diff infection, during our conversation. Look, it can infect anybody. This can happen to anyone, but almost always this occurs when someone is taking or has recently completed a course of antibiotics. Antibiotics given for a different reason. People are 7 to 10 times more likely to get C. diff infection while they're on antibiotic and during the subsequent month. Why? Because that's how C. diff works. C. diff happens when we prescribe antibiotics to kill bacterial infections anywhere in the body. You could be going for the sinus, you could be going for the urine. It's all good, but unfortunately, there is collateral damage. That happens when the beneficial microbes of our gut microbiota become inadvertently collateral damage. They're killed off by the drugs that we're prescribing for a totally different reason. Innocent bystanders in the gut killed off, and the only thing left behind, stupid old C. diff that then has nothing else to keep it in check. That biological competition is removed and it goes hog wild, grows like crazy, and makes a lot of poisons. I want to emphasize any antibiotic can do this. Even metronidazole, Doug, can do this. We used to treat C. diff with metro. Metro itself can cause C. diff. So any antibiotic can do it. But I want to emphasize that in primary care, I used to be a primary care doctor myself, and I've been burned this way myself. Not every drug has equal likelihood to do this. The one that I really want to call out, clindamycin. Clindamycin is a drug that is higher than most others to trigger a case of C. diff. And I'm calling it out because in my experience, most primary care doctors do not like using Clinda. They know about this. When they reach for it, it's often because their patient has a penicillin allergy label on the chart, because they're worried about giving a cephalosporin or a related penicillin, maybe uncertain about whether this is a real penicillin allergy. Is it a serious penicillin allergy? I'm just calling this out because we have new information, new technology, and new tools that can rapidly help primary care providers quickly, safely, and accurately categorize those patients. Doug, if you invite me back, I'm happy to talk to you more about penicillin allergy labels in primary care. I'm all fired up about this. Anyway, in general, try not to use clindamycin if you can. Other risk factors aside from antibiotics for bad outcomes, especially with C. diff, age at 65 and older, recently in the hospital or the nursing home, people with a reduced immune system for other reasons like organ transplantation, taking immunosuppressives, biologics, people battling cancer, people living with HIV. And then, of course, people who've recently had a C. diff infection, or they know that they've been exposed to someone. For example, they went to a skilled nursing facility, they were cohorted in the same room with someone who was having diarrhea. All of those are independent risk factors for C. diff. And if I'm not mistaken, age over 65, recent hospital admission, immunosuppression, a lot of people have many of these factors, and they can all come together to really increase the risk of those people getting into trouble with C. diff. I would also emphasize the factors associated with a lower likelihood of having a true case of C. diff, and this should be no surprise, but if your patient has another obvious reason for diarrhea, they may not have C. diff, even if they have a positive test. I'm thinking about patients who get started on tube feeds, patients given laxatives for constipation, patient with liver disease, you get them onto lactulose. All those people will have medical or other induced reasons for diarrhea. So friendly reminder, antibiotics cause diarrhea and other medications can as well.
Well, could you comment on proton pump inhibitors? That's been in the news. There was I think, a warning letter sent out in 2012, letting us know that that's something to be concerned about in people with Clostridia difficile or put them at risk. What's your take on that, and what should we be our bottom line as primary care clinicians?
Yeah, I like that so much. The concern, the theory of why that may be an association is that, well, C. diff is spread to us via spores. The spore is a relatively inactive vegetative state, pretty tough in the environment. Hydrochloric acid tends to help inactivate the spores. There is an association between PPI use and people subsequently developing C. diff infection. Maybe it's because we have increased their gastric pH. That's not unique to C. diff. That's true for salmonella. It's true for a whole bunch of travelers' diarrhea syndromes. So stomach acid, love that stuff, unless it makes your patient sick. So the way I put this together is to say, the busy primary care, let's face it, Americans, half of them are on a PPI, the other half want to be. I mean, these are very, very powerful drugs. They're very attractive to use. I think we should just remain choosy about them for a whole bunch of reasons. This is yet another reason to really ask ourselves, does that patient need a PPI? And if they do, can we limit it in time? I'm okay with a short course. It's these lifelong courses that make me, well, it does place patients at higher risk, I think, for C. diff.
Now that we know who's at risk, let's turn our attention to workup. What tests are at our disposal, and is there one that is better than another? And specifically, when I order a test, I get these pop up in Epic, and I may want to just order something for C. diff, and all sorts of choices pop up, including large panels. So if you could walk me through some of that, that would be really helpful.
Yeah, my pleasure. Totally. I agree. So if you're thinking C. diff infection, you got to check the poop. I wish it was like H. pylori, where you could do a breath test. Actually, hopefully someday we will have that. I don't see why not, but at the moment we don't. We are stuck asking the patient for a stool specimen. And by the way, that's another pearl. It's just striking to me how often that does not happen within a couple of days. The patient has diarrhea, you're worried about C. diff, you send them home with instructions to collect a stool. A few days later, where's the test? Oh, doc, my diarrhea, I'm waiting to have my next poop. That's not C. diff. Okay, that was some other thing that happened. If the patient's not able to pass a liquid stool on the day that you order the test, their chance of having a real C. diff infection is close to zero. Indeed, by definition, to have C. diff, you have to have multiple liquid stools per day. Liquid meaning it takes the shape of the cup that they crap into. So you can safely cancel the test if they can't actually give you diarrhea. But having said so, for most outpatient providers, there are usually three tests to choose from. The first is what you mentioned, Doug. That's the multiplex molecular test. It's looking for the genetic signature of C. diff and simultaneously looking for the genetic signature of a whole host of other pathogens all at the same time. And I suspect our listeners will be very familiar with this family of tests. They go by different names. They're quick, they're generally reliable, and I actually like them for community-acquired diarrhea, where your patient could have only one risk factor or maybe no obvious C. diff risk factors, especially if that patient has not recently had antibiotics. We keep an open mind that there could be a different infectious cause of diarrhea, bacteria, parasites, viruses. The nice thing about these multiplex tests, it looks for all of them at the same time. Having said so, no test is perfect, right? They're expensive, they're not perfect, and we do encounter issues with both positive and negative predictive values of the results that come from those multiplex tests. For example, if you get a result back with multiple positive hits, including C. diff, plus other pathogens, man, please consider reaching out to your friendly local infectious diseases specialist. Consult with them, get some of their thoughts about how to interpret those multiply positive results, because it's unlikely that this patient really has more than one thing at the same time. And likewise, if the clinician has a suspicion for C. diff that's high, based on those risk factors we talked about, but the multiplex is negative, and maybe a false negative, you may benefit from a different test in that circumstance. Your clinical suspicion may supersede the accuracy of what happens in the lab. So for me, in those high suspicion situations, actually the ideal test is a C. diff specific molecular test. A nucleic acid amplification test, we usually just call them a PCR test. It probably outperforms the multiplex test by a small margin, even though they're based on a similar technology. So I think a C. diff specific test, that's the test of choice if you really have a high spidey sense, high suspicion for C. diff. Now, finally, there's a third test, which you'll probably be familiar with as well. That's a non-molecular antigen assay. Those antigen assays, they're not looking for bacterial DNA, instead just the broken shards of C. diff bacteria itself. And it makes good sense. The idea is that the molecular tests are very sensitive, but potentially less specific because they detect both colonized and infected patients. In theory, the antigen test could be less sensitive but more specific. That's the theory. In fact, some hospitals use a so-called two-step testing, which patients might get a PCR first and then an antigen to confirm. It's a lovely story, but it's just not correct. Unfortunately, the antigen test, it's just not reliable in distinguishing infection from colonization. I wish it were. That would be a great thing. but that is just not the way they were developed, and they're not reliable in that fashion. So I would say, regardless of which of those three main tests a clinician is using, just very important to test wisely, and only to test when we have an elevated pre-test suspicion for C. diff.
This is a good time to share a case with you and discuss recommended treatment approaches. Let's hear from Dr. Lydia Calamari, an internist at Atrium Health in Charlotte, North Carolina.
James is a 68-year-old who presents for 1 week follow-up of a hospitalization for community-acquired pneumonia. Today he states his cough has almost completely resolved, but for the last 2 days he has experienced a return of fevers as well as frequent urgent episodes of diarrhea. He describes abdominal cramping in his lower abdomen and at least 10 episodes of loose, non-bloody, malodorous stools each day. He is hydrating well, able to eat, and denies lightheadedness, dizziness, or chest pain. He has no history of bowel disease, had a normal colonoscopy just 1 year ago, and no recent travel. His medical history is notable for well-controlled hypertension, coronary artery disease, and GERD, and his medications include carvedilol, lisinopril, aspirin, and omeprazole. On exam, his blood pressure is 125/70, heart rate 90, and temperature 99.8, respiratory rate 16, and satting 97% on room air. His lungs are clear. His abdomen is soft, with mild tenderness diffusely throughout, and most notably in the left lower quadrant. Bowel sounds audible without a stethoscope. Upon chart review, while in the hospital, he initially received a dose of both vancomycin and ceftriaxone for the pneumonia, then was continued on just ceftriaxone for 3 days before transitioning to oral cefpodoxime for 2 additional days. He also received doxycycline for 10 days just over 1 month ago for cellulitis. You obtain a CBC with diff, basic metabolic panel, and he is able to provide a sample which you send off for C. diff antigen. The test is positive, and his labs are also notable for a white blood cell count of 18,000, normal kidney function, and electrolytes. What treatment would you recommend?
Paul, let's start with an overview of the IDSA clinical guidelines, which were updated in 2021. What do those guidelines recommend for somebody like James?
Yeah, thanks, Doug. I mean, the case strikes me, first of all, as a very classic presentation. Appropriate management, appropriate antibiotics, everything went well, and then this. As if pneumonia is not bad enough, now this. So I've seen this in my practice many times, and I suspect our listeners have too. What I really appreciate in the synopsis you gave is the fact that, at least for the moment, the clinical assessment, I think, suggests, yeah, this patient can take care of himself at home and should not necessarily need to be admitted. Now, that's not always the case with C. diff infection. Sometimes people develop symptoms at home, and then they just get so dehydrated that they need supportive care, at least for the beginning portion of their treatment. But again, in this case, it sounds like clinically stable and patient can probably be safe at home. If so, and they can get on treatment, I'm optimistic that they'll actually start to feel better within the next 48 hours. And assuming they can keep up with their fluid loss, they can probably stay at home for the whole course. I'm also noting from the synopsis, as far as we know here, this is the first C. diff infection in a lifetime for this patient. So for outpatient treatment of an initial C. diff infection, that's how we categorize this patient. First, please know that actually, you're right. We have new guidance from the Society of Healthcare Epidemiology of America, SHEA, jointly with the ID Society of America. I'm a card-carrying IDSA member. There are new guidances there. But please understand that the most important core teaching has not changed in generations. And that is what we have always taught and been taught. But we sometimes need to be reminded, so I'm going to say it out loud. If your patient is still getting antibiotics for a different reason, you got to stop those antibiotics immediately, if at all possible. Now, this patient is actually status post antibiotics, so that's not necessary to consider here, but that comes up a lot. C. diff infection happens because of that imbalance of our healthy microbiota. We call that a gut dysbiosis. That's the term we use. Antibiotics aimed at the bladder or the sinus have inadvertently crushed the beneficial microbes of the colon as a kind of collateral damage, and that allows C. diff to flourish and release the harmful toxins. So We have to take away that selective pressure, allow the healthy microbes to come back if at all possible. It's not always possible. And I would not ask you to cut short a treatment course for endocarditis or tuberculosis. You just can't do that. But it is amazing to me and surprising how often patients get, well, they get treatment courses that are a bit longer than society guidelines for suspected infection, the respiratory tract, the urinary tract. So I'm just going to put that there and leave it at that, a chance to reassess. Does that patient still need their other antibiotic? So once we've set the stage for the successful return of the healthy microbes by stopping their antibiotics, yes, now we have to kill the bad bugs. We need to kill the C. diff with C. diff specific antibiotics. And the more specific, the better. Our current guidelines emphasize the benefits of using an antibiotic called fidaxomicin. So let's talk about it. The authors of the guidelines suggest that fidaxomicin should be first-line treatment for all patients with C. diff infection, including those just having their first episode. They also emphasize that oral vancomycin is, yes, it is acceptable as an alternative if you have difficulty getting a hold of fidaxomicin. That's not because fidaxomicin is better than vancomycin at getting your patient better in the short term. Both fidaxomicin and vancomycin should do the same. They should have the same response in the same timeline. They both work very well to make your patient better. I need to emphasize that. No, the authors of the guideline suggest fidaxomicin as their top choice, not because it's faster, but because it can have a modest reduction in the risk of recurrence down the line. I'm talking about a risk ratio for recurrence of 1.16 among those treated with vanco versus fidax. That is a 16% higher risk of recurrence with vanco than with fidaxomicin. So why does that happen? Why is fidaxomicin a little bit better when it comes to the risk of recurrence? Well, probably because fidaxomicin, it's a more of a narrow spectrum. It's a more specific killer of Clostridium. Vancomycin also does some collateral damage, even when swallowed PO. So as I mentioned earlier, recurrent C. diff is as common, and we'll talk about this in more detail in our next episode, but treating recurrent cases, I hate doing that, Doug. So anything I can do, it seems to make good sense to do this to reduce that risk of recurrence. Therefore, fidaxomicin suggested as our leading choice. Having said so, why would we ever choose something else? Well, usually because of access. Access, I think, is that the word we still use when in academic medicine when we mean it costs too damn much? A course of fidaxomicin, if someone were to pay cash at a pharmacy, would be more than $1,000 for the 10 days. On the other hand, a course of oral vancomycin, if you got it from your hospital compounding pharmacy like we do, less than $100, less than 10% that cost. And we also now have an FDA-approved formulation of oral vancomycin. That's new within the last few years. It is also much cheaper than fidaxomicin. A course would be cash price about $200 as opposed to more than $1,000 with fidax. So, as any doctor who can tell you, who's been around the block more than once or twice, money in medicine, it's crazy, right? It's hard to predict. It's hard to tell. Let's face it, very few of our patients would ever pay cash for any prescription medication, I hope. Instead, it comes down to that morass, their insurance coverage, availability at local pharmacy, their copay, their supplement, all of that goes into this. So in the context of outpatient medicine, the good news is that fidaxomicin, hey, it's FDA approved for this indication. It is used as guideline-based care. Pretty hard, I would hope, for insurance carriers, Medicare, Medicaid. They should have a hard time saying no, even though it's expensive. But the devil's in the details. It does come down to their copay. It does come down to that crazy complicated situation. Frankly, it's one of the reasons I chose ID, so I don't have to deal with this as much. I can only tell you that in my own clinical experience, Doug, most of the patients, when I prescribe fidaxomicin, yes, most of those patients are able to get it without a prohibitively high copay. But as the old saying goes on TV, your results may vary. So I think if your patient cannot get fidaxomicin, either because it's not available or it's too damn expensive, these patients instead can receive oral vancomycin, and you should feel great about prescribing that. Now, whether you choose fidaxomicin with a dose of 200 milligrams by mouth twice daily, or vancomycin 125 milligrams by mouth 4 times daily, in either case, the duration is the same. 10 days of treatment, please, for their initial case.
So, Paul, in any way, does your approach differ from what's in the IDSA guidelines? I struggle sometimes myself when I look at guidelines, and then we have our own personal touch to it. And you've done a nice job talking about the practicalities of this. So for our listeners, kind of what are the the things that are most important there that you do in your approach, and maybe pointing out some of the things that are in the guidelines that maybe in the real world we don't always do.
Yeah, I appreciate that a lot. So, it's interesting. I'm an ID doctor. I work at a referral center. I don't see a lot of de novo primary first-time C. diff. I see the cases that primary care refers to me when they've done the guideline care. So my practice, we'll talk more about this in the next episode. I do all kinds of stuff that may not be exactly to label. Having said so, for outpatients, I think the guidelines I mentioned above makes perfect sense. But having said so, I'm not a primary care doctor. No, I think what I'm more commonly dealing with, honestly, is the inpatient hospitalized situation. And these patients are very complex and it's also very expensive. As you know, we get paid in hospitals, at least my hospital, under a DRG. I call it the diabolical regressive gauntlet of medicine. I think it has another meaning. You could look it up yourself, diagnostic related group. Anyway, it's a four-letter word to me. I hate the DRGs. And what it means is that as we spend more money on medicines, the hospital has to end up taking it on the chin financially. And as I said before, because fidaxomicin is so expensive compared to Vanco, look, at my hospital, the University of Washington Medicine System, for us, first line treatment for an initial case of C. diff is usually vancomycin because it works very well, although it has a slightly increased risk of recurrence, and it's just dramatically more affordable. Now, for us, fidaxomicin, I would usually use that either in a recurrent infection, as we'll talk about, or in the initial infection for people at high risk of recurrence. So if patients have two or more of these factors, age 65 or greater, prior C. diff in the last 6 months, severe immunocompromised, membranous colitis on their scope, that's when I would reach for fidaxomicin up front. Otherwise, I'm still old school Vanco in many of those cases.
Paul, is there any use for metronidazole for the treatment of C. diff in 2024?
No. No, there's not. You can. We've all used it for a long time. It's okay. It's just not as good. Fidaxomicin and vancomycin are superior. They're better tolerated. I would only use metronidazole if I couldn't get either of the other two. That's the old joke, right, Doug? Vancomycin's what you give your mom. Save the metronidazole for your mother-in-law. By the way, she's a nurse and she's probably listening to us right now. I would give you vancomycin, Jane, if I had to. So metro, just not on the menu.
Okay, thanks so much for clearing that up. And the reason I asked that, Paul, is this study that was published earlier this year. Stabholz and Paauw published the results of a meta-analysis that challenges recommended management strategies. Specifically, it found that there were no significant differences in mortality in individuals with treatment with vancomycin and fidaxomicin or metronidazole. We will provide a link to the listeners so they will have that. So, Paul, what do you think about these findings, and should they have any impact on practice related to patient outcomes?
No, I do not think so. I appreciate the paper. This is a meta-analysis of 13 separate previous papers, and as you said, they found no difference in mortality, life or death, among those who received metro or vanco or fidaxomicin. However, the risk of recurrence substantially higher among people who got metronidazole. So to me, this meta-analysis, it's yet another one of the many studies that confirms our current understanding. Oral vancomycin is better than metronidazole, and fidaxomicin may be a bit better than vanco. Look, I know our listeners have prescribed metro many times, and I have too. I got to tell you, I hate that stuff. It's so toxic. It's hard for the patients to take if we compare with the clean alternatives we have here. And I also worry that metronidazole looks okay here because we're testing for C. diff a lot using those molecular tests. Not all those patients even actually have C. diff infection. I think we're treating a lot of people who are colonized, and it's almost a placebo effect. So bottom line, you could use metro if you wanted to, but I would not do so unless I really could not access vanco or fidaxomicin.
Great. Well, Paul, thank you so much for taking the time to give us a better understanding of this important topic and how management strategies are changing. Let's close by summarizing a few take-home points. C. diff is incredibly common, and we need to know the risk factors for patients with Clostridia difficile, especially think about it in patients who are nursing home patients, hospitalized patients, patients who have received recent antibiotics or still on antibiotics, and especially, as you pointed out, patients who have had a history of Clostridia difficile infection. Fidaxomicin is really the appropriate first-line therapy. If we're unable to get it, pivoting to vancomycin is a very appropriate thing to do depending on what situations there are for us on getting the medications for the patients. And The third point is there really is no real role for metronidazole in the treatment of C. diff infection. I don't want to come across as saying never, but if you have any other option, it's probably better than metronidazole.
The opinions expressed are those of the reviewers, authors, and commentators and do not necessarily represent the views of Oakstone Publishing. Please review the complete prescribing information of specific drugs or combinations of drugs, including indications, contraindications, warnings, and adverse effects before administering pharmacologic therapy. Thanks for listening to CME Essentials in Internal and Family Medicine. To learn more, visit oakstone.com.